A very good evening, everyone. This is Rohan Tripathi from Innovocare Health of Solutions. So today we are here with another web CME. The title of today's evening is COVID-19 and hyperglycemia, which is commonly known as high blood sugar. The reason for this topic and the importance of the COVID-19 treatment and its importance for the hypoglycemic people or the people with high blood sugar and diabetes is something that is a topic of much discussion, has been discussed time and again. And we tonight thought that it was a thing that was required to be discussed once more. We have as our eminent speakers Dr. Arindam and Professor and Dr. Shambo Samajdar. We have as the chairpersons for today's evening Dr. Eminent Clinical Pharmacologist Dr. Santanu Tripathi and eminent senior endocrinologist Professor Shashankar Joshi, who is also the recipient of the very respectful Padma Shri Award. So, to begin with, I would like to welcome Dr. Shantanu Tripathi to begin today's proceedings with a few words, and then go on to welcome Dr. Arindam for his session. Dr. Shambo Samajdar has also joined and will be with us soon. And we are hoping that Professor Shashankar Joshi will also be with us in the due course of the evening. So, Dr. Tripathi, could you please join?
Thank you very much, Rohan. So now, good evening, everybody, and welcome to this evening's program. And as has been already mentioned by Rohan of Innovocare, that today's topic is the topic that we are going to discuss: COVID-19 and hyperglycemia. And we have two eminent speakers who will be addressing two different aspects. Dr. Arindam Roy, who is a DM endocrinology, affiliated to College of Medicine and Sagore Dutta Medical College Hospital. And Dr. Roy, would be speaking on in-hospital hyperglycemia and management in hyperglycemia management in COVID-19 patients. And there is another session which will be by Dr. Shambo Samajdar, who is DM in clinical pharmacology. He is associated with School of Tropical Medicine, and Dr. Samajdar will be speaking on steroid-induced hyperglycemia in COVID-19. We are also fortunate to have amongst us Padma Shri Professor Shashank R. Joshi, who is otherwise well known in to the medical fraternity. Dr. Joshi, I am told, is otherwise a little occupied with some other session, some other function. So perhaps he will be joining a little later. But without wasting any further time, I would request Dr. Arindam Roy to first. Arindam Roy will be speaking first, I suppose. So Dr. Arindam Roy will be speaking on in-hospital hyperglycemia management in COVID-19 patients. Dr. Roy, please. Rohan, there is some background noise, I think. If you can try to, Rohan.
Hello.
Sir, you want
is the
Dr.
screen
Roy,
visible?
Screen is visible. There is some background noise, hissing sound, but otherwise, if it is not very disturbing, Dr. Roy can start.
Sir, am I audible and visible? My slides.
Yes, sir.
Yeah,
Yes.
you are audible and your slides are visible. You can make it full. Yeah.
So, okay, sir. Thank you for your kind. Yeah. So thank you for your kind introduction, and yeah, good evening, everybody. Thanks, Innovocare, for giving me the opportunity, and thanks, Dr. Shambo Samajdar, for also accepting me as a speaker here in the platform. So today my topic of discussion, as told by sir, that in-hospital management in the COVID-19 patients. So for the last 1.5 years, but the experience we gathered as a faculty working in a COVID hospital of Sagore Medical College, that the management of COVID is actually the morbidity, mortality. This all depends on the severity of the disease, and the severity of the disease actually depends on the comorbidities the patient that have. So in the due course of time, I will disclose everything, but to say that diabetes management from that aspect is very important. Here actually we have to decide from the very first day of admission that which patient actually requires what kind of anti-diabetic management, that actually decide in the due course of time whether the patient will safely go home or they can land up in the ICU. So it is not required to say, next slide, not required to say about the COVID-19 because we are familiar by this time with this virus that is first identified in the Wuhan city of China in December 2019. It's an enveloped RNA virus which actually known as the SARS-CoV-2. It's the seventh coronavirus to infect the humans. Slide, please. Mr. Rohan. Yeah. Thank you. So also, the SARS-CoV-2, the MERS-CoV-2 and the SARS-CoV that can cause a severe disease, whereas the HKU1, NL63, OC43, and 229E are associated with the mild symptoms of the same category. So SARS-CoV-2 that causes the disease known as COVID-19, the coronavirus disease 2019. Next slide. Next slide. Yeah. So as I was telling that the prevalence of the comorbidities in COVID-19 infection, the meta-analysis of these 8 studies with 46,248 COVID-19 patients that clearly shows that hypertension, diabetes, cardiovascular disease, and respiratory system diseases, particularly the COPD, are the most important one from statistical point of view. Next slide. So if you just go by the studies, the different studies that actually says the similar thing, apart from the age, the sex ratio, the exposure history, the underlying diseases that actually shows a very significant factor like the diabetes, hypertension, cardiovascular disease, malignancy at the same tune. Next slide. And this is, the comparison of the time-dependent risk of reaching to the composite endpoints, and the time-dependent risk of reaching to the composite endpoint between the patients, that is the orange curve, or the without any comorbidity, with the comorbidity and without any comorbidity, which is, here painted as in the dark blue curve. And it is very clear that if the patient have the comorbidities and if the patient do not have the comorbidity, that clearly shows the mortality difference, that is the total cumulative failure with time. Next slide. COVID-19, the higher the ICU admission for the people with diabetes, and this is published data from United States that says that when the patients, the patients with this COVID-19 have this diabetes, have the disease diabetes, then the patients are actually, are more complicated in the form of, if you just see in the first bar, then the patients who have the diabetes, actually, the not hospitalized rate is the minimum. When the patients are hospitalized, even the non-ICU admission, and you can see the difference with the ICU admission. So as the the patients are going deteriorating, that is from home care to hospitalization to ICU admission, the the association of the diabetes process that is actually increasing. So you can say that the 58% of the COVID-19 patients that is admitted to the ICU had the diabetes, and hospital admission and critical illness was higher for the people with the diabetes. Next slide. So this is definitely, the diabetes is a risk factor for mortality of the COVID-19. So there are multiple studies are there, but this is one study, a large national sample study in the China that showed that the mortality of the patients with diabetes was significantly higher than that of the non-diabetic patients, and the ratio here statistically significant. At the same time, the Chinese CDC declared that the patients who reported no comorbid condition has a case fatality rate of 0.9%, while the patients with the comorbid conditions had much higher rates, the 7.3% for the diabetes. It is very clear from the right-sided bar diagram. Next. The similar studies from the Italy and also from the New York State clearly says the same thing, that is the diabetes was present in over more 8,988 of the 20,061 patients who died. That is 39% of the whole cohort. Next slide. Now, it is not only the diabetes. So, actually the blood sugar is more important, and the study says that fasting blood sugar correction is actually very much important, to the decrease the morbidity mortality from COVID-19 point of view. Here, the study that actually shows the COVID-19 patients without the previous diagnosis of diabetes from two hospitals, and if the fasting sugar at admission is less than 6.1 millimole per liter, and if the fasting sugar is at admission more than equals to 7 millimole per liter, you can see the difference from 28-day mortality and 28-day complications. The hazard ratio of 28-day mortality were 2.3 in favor of the fasting blood glucose of more than equals to 7 millimole per liter, whereas the 28-day complication, the odds ratio also 3.99 in the same group of fasting blood glucose at admission of more than 7 millimole per liter. So definitely the 28-day mortality and 28-day complication rates are higher in patients who have a fasting blood sugar of more than 7 millimole per liter at admissions in COVID-19 patient. Next slide. But why this association of diabetes with the COVID-19? Because the people with diabetes have an increased risk of infection because of the innate immunity defects that's linked to the hyperglycemia, and also both in the acute and chronic effects. There is increased risk of severe infection because of the increased cytokine storm. Next slide. The glucose and the glutamate are preferred by the SARS-CoV-2 virus, and COVID-19 infection will heighten the state of insulin resistance in diabetes, particularly because of the different cytokines that play the role. Interleukin-6 here to specially mention because produced as the result of the COVID-19 infection that increases the chance of fatal consequences of the infection in diabetes mellitus. Next slide. So to share in the nutshell that this SARS-CoV-2 virus that actually directly also damages the beta cells of the in the pancreas that can cause also the cytokine storm, releasing different cytokines including the interleukin-6. There is also at the same time at admissions of hyperglycemia, the worsening of the metabolic control in patients with diabetes, and also probably the new onset diabetes that can happen because of the two factors I've already mentioned. In the patients who have the obesity, increased inflammation, increased coagulation, the hyperglycemic conditions, like the DKA or HHS, at the same time the older age, the other comorbidities like hypertension, cardiovascular disease, also the CKD or the renal disease that ultimately gives the poor outcome. Next slide. So the glucose management strategy that I will tell you in the next few slides for the different types of diabetes in patients with COVID-19. To say the type 1 diabetes, definitely the treatment of choice will be the insulin pump or the basal bolus regimen, and recommended insulin analogs as a first choice, and insulin treatment should be individualized here. In type 2 diabetes, for mild COVID-19 patients with low or moderate, the glucose increase, the low insulin diabetes drugs can be used, non-insulin diabetic drugs can be used. For patients with the fever or treated by glucocorticoids, the insulin treatment will be the first choice. For critical patients, particularly the ICU admit patients, the IV insulin is recommended. For glucocorticoid-associated diabetes, it's very important to monitor the blood glucose after the lunch and before the dinner. As the glucocorticoid-induced, this blood sugar often occurs between after lunch and before the sleep, and insulin definitely is the first choice. But I will not, elaborate this glucocorticoid-associated diabetes, as Dr. Samajdar in the next presentation will depict that. Next slide. So this is a suggested algorithm for the screening of hyperglycemia in patients admitted in a COVID care facility. The first step will have to check the random blood glucose of every patient, those who are admitted in the COVID-19 ward. The step 2 will be to perform a pre-meal and a 2-hour post-meal CBG with the first major meal in the hospital. The third step will be to send the blood samples for the fasting plasma glucose and the HbA1c in the next morning if the lab facilities are available. So what will the step 4? We have to monitor the capillary blood glucose before breakfast, before lunch, before dinner, and after dinner for at least 2 days for underlying hyperglycemia if any of the test values are high. What are the test values? If the random capillary blood glucose at admission more than equals to 180 milligram per dl, or the pre-meal, the CBG will be more than equals to 140 milligram per dl, or the post-meal 2 hour more than equals to 180 milligram per dl. If the from laboratory values, the fasting plasma glucose more than equals to 110 milligram per dl, or the HbA1c more than equals to 6 milligram per dl. Then the last step will be step 5 to initiate the pharmacotherapy if any of the test values meets the given glycemic thresholds. If the random Cbg more than equals to 250 milligram per dl at admission, if the pre-meal Cbg more than equals to 150 and the post-meal 2 hour more than equals to 200 milligram per dl, or the fasting plasma glucose from laboratory more than equals to 126 milligram per dl, and HbA1c or HbA1c more than equals to 6.5%, that gives the definition of true diabetes. Next slide. Now, the blood glucose monitoring strategy for individuals with no evidence of stress hyperglycemia or undiagnosed diabetes at the initial screen. So, if there is no hyperglycemia at admission, but if the severity of the illness of COVID-19 increases, the patients admitted in the ward and then shift to the ICU, or if the EWS, that is the early warning score, that is deteriorating, then definitely we have to reinitiate the blood glucose monitoring before breakfast, before lunch, before dinner, and after dinner for at least 2 days, which can be decreased to twice a day if the values are normal. Otherwise, if the patients are treated with the glucocorticoids, then definitely we have to again reschedule the monitoring as a before breakfast, before lunch, before dinner, and after dinner for 2 days, and we can decrease otherwise. If the patients are high-risk individuals, like the patient have the cardiovascular disease, if the patients are obese, if the patient have the age of more than equals to 50, then definitely we have to monitor the blood glucose twice a day, every 3 to 4 days. Next slide. Now, if the patients who are known diabetics, next slide. Then the guidance on the use of the oral glucose lowering agents, like if the patients have the no contraindication for the oral glucose lowering agent, like if the patient have the normal renal function, normal hepatic function, if the patient have the mild COVID, that is the EWS score is less than 4, then definitely we can treat the patient with the oral hypoglycemic agent. And the mild hyperglycemia will be there, that is if the pre-meal of Cbg will be less than 180 milligram per dl, whereas the post-meal 2 hour less than 250 milligram per dl. Now, what are the different oral hypoglycemics that we can use? Definitely, what are the SAPes, the DPP-4 inhibitors? That is the first choice will be here, particularly the teneligliptin, sitagliptin, dinagliptin we can use. The vildagliptin can be used here if the liver function test is normal. We have just experienced a lot of patients with the COVID-19 have the increased transaminases. So in this situation, if the transaminase value or the SGPT, SGT values are more than 3-fold of the normal, then definitely vildagliptin we have to use cautiously. If it is more than 5-fold, then definitely it is not to be used. Otherwise, the metformin, definitely we can use the metformin, but we have to also take care of the serum creatinine value. We have to calculate the EGFR. So if the EGFR is less than 30, then definitely metformin we have to stop. We can't use. If it is less than 45, maximum of metformin 500 milligram we can give. Sulfonylurea, definitely one of the very good choice, but we have to be cautious about the hypoglycemia in these situations. SGLT2 inhibitors and the pioglitazone is not a good option in these situations because of the chance of the dehydration, the hypotension, at the same time the euglycemic ketoacidosis from the SGLT2 inhibitor. And pioglitazone, there is risk of fluid retention and the edema, so it is contraindicated in cardiac or the hepatic dysfunction patients. Next slide. Now, the patients who are detected to have the hyperglycemia at admission, not known to be the diabetic previously. Next slide. So we can definitely use the metformin or the gliptins I already mentioned, provided the patient meets all the following criteria. So what are the criteria? If the pre-meal, the blood glucose is between 150 to 180, and or the post-meal blood glucose is between 200 to 250 milligram per dl. If the patient is conscious, definitely oriented, and has a good oral acceptance, there is the diet he or she can follow normally. If the COVID symptoms are mild, or the kidney function or the renal function, the liver function within normal limit. Here we definitely have to initiate this oral hypoglycemia, oral hypoglycemics along with the calorie restricted diet, and that should be maintained thoroughly. But do not initiate the drugs like pioglitazone and SGLT2 inhibitors in patients with COVID-19, as I've already mentioned the cause. And in moderate to severe COVID, we have to definitely stop the pioglitazone and SGLT2 inhibitors if the patients are already taking them. Next slide. If the blood glucose level at admission are above the range of the pre-meal of more than equals to 180 milligram per dl or the post-meal blood glucose to more than equals to 250 milligram per dl, definitely the choice of therapy will be insulin. Here we can we have to avoid the oral hypoglycemic agents. Next slide. So patient is on oral anti-diabetic and the blood glucose levels are uncontrolled. Then what we had to do? Next slide. If the pre-meal blood glucose value is 140 to 180 and or the post-meal value is 180 to 150, then we can do the oral anti-diabetic optimization. We have to increase the dose if it is not getting the optimal dose. If the pre-meal blood glucose value is more than equals to 180 milligram per dl and the post-meal blood glucose more than equals to 250 milligram per dl, despite being on the optimal dose of the OAD, then definitely we have to start the basal bolus insulin regimens. And oral antidiabetics, apart from metformin and gliptin, in this situation, we have to stop. Next slide. Now, the bolus insulin that we can use is the regular insulin or the insulin analogs that may not always be needed for all the 3 meals and can be only added if the individual meal requiring the prandial coverage. That if, for example, if the meals with the pre-meal to post-meal blood glucose difference is more than 40 milligram per dl on a given day, the regular insulin or the analog insulin we have to add before these meals on the next day. If the fasting plasma glucose is more than equals to 140 milligram per dl and the post-meal increment, as I've said, in the blood glucose level is normal, that is less than 40 milligram per dl, then definitely we don't have to use the regular or the analog insulin. Here only the basal insulin or the intermediate acting insulin like NPH insulin, bedtime or 2 hours after the dinner we can use to control the fasting plasma glucose only. Next slide. Now the patients who are on the rice tube feed. Now this is a very, the situation many times happens, the patient have some comorbidities like, the patients have the cerebrovascular accident. So the patient's actually not able to take food orally, the patient have to be fed by rice tube. So what should be done in this case to control the blood glucose? Next slide. So here we have to just follow the rule that rice tube feed should be divided into 3 major and 3 minor feeds. The major and the minor feeds are defined by the calories or the quantities of the feed. For example, the major feed kind of 300 ml each and the minor feed of 150 ml of each, and the timing is very important here. The major feed timing will be 9 a.m., 1:30 p.m. and the 7 p.m. whereas the minor feed time will be 11 a.m., 4:30 p.m. and the 10 p.m. And definitely we have to use the basal bolus insulin regimen will preferred in such patients. The bolus insulin, that's the regular insulin or the analog insulin, that should be given 30 minutes before the each major feed. If the regular insulin be used, for the analogs kind of 5 minutes. If the fierce insulin kind, if you use, then definitely we can give the insulin even after just after the feed. And the basal insulin, the NPH insulin or the insulin glargine, that should be given at 10 p.m. along with the last minor feed. And the capillary blood glucose monitoring here to be performed before and 2 hours after each major feed. Next slide. So this is the guidance of the use of the insulin therapy. So we have to prescribe the insulin if there are contraindications to the oral glucose lowering agents, or the patient deteriorating to moderate to severe COVID, or the patient have the moderate to severe hyperglycemia, as I've already mentioned, the pre-meal value of more than equals to 180 milligram per dl and the post-meal value more than equals to 250 milligram per dl. The basal bolus insulin regimen, we have to start with 0.4 units per kg per day. We have to consider the lower dose of 0.2 units per kg per day if the patients are elderly, if the patient is frail, or the patients have the renal or hepatic failure, that's to avoid the hypoglycemia. And then deciding the basal bolus, the component, we have to divide equal into 4 doses when using the regular and NPH insulin, and divide we have to equal into the 2 doses, 50% of the basal and 50% in the bolus if we use the insulin analogs. And the blood glucose target in the case pre-meal of less than 140 milligram per dl and post-meal less than 180 milligram per dl. Now, one, we will prefer the intravenous insulin infusion, that if the patient have uncontrolled hyperglycemia, if the patient have some situations like sepsis with or without shock, or the hyperglycemia with erratic diet, or the patient have some emergency situations like DKHSS. And here insulin infusion will be started at the rate of 0.05 to 0.1 unit per kg per day. And target blood glucose in this situation will be 140 to 180 or 200 to 220. I will just elaborate it in a few slides later. Next slide. Yeah. So this is the guidance for deciding the initial doses of insulin for steroid-induced worsening of the blood glucose in people with or without diabetes. So if the patient have no previous diabetes, then definitely we have to use, the 0.2 units per kg per day, the NPH insulin here 0.1 unit per kg in the morning, because the steroid induced diabetes, though Dr. Samajdar will elaborate it later, but to say here the steroid induced diabetes, usually the single dose is if given in the morning, then definitely the chance of hyperglycemia will be the maximum after the meal or in the evening time. So here NPH insulin is better to give in the morning hours, and we have to add the regular insulin 0.1 unit per kg before lunch. If the patient already on 1 or 2 oral glucose lowering agents for diabetes, and definitely the total dose will be 0.4 units per kg per day. Here NPH insulin again 0.1 unit per kg in the morning or the evening, and regular insulin 0.1 unit per kg before breakfast, before lunch, before dinner each. If the patients are already on more than 2 oral glucose lowering agents for diabetes, then the initial total dose will be 0.6 unit per kg per day. Here NPH insulin 0.2 units per kg in the morning and 0.1 unit per kg in the evening, and regular insulin 0.1 unit per kg before breakfast, before lunch, before dinner. Which if the diabetes on insulin of more than 0.6 unit per kg per day in the beginning, then definitely we have to increase the dose in 1.2 fold in the patient's insulin dose. There's 20% extra insulin we have to give. 50% of the NPH insulin, 2/3 in the morning, 1/3 in the evening, and 50% will be regular insulin. That has to be equally divided initially for the before breakfast, before lunch, and before dinner each. Next. So, this is the suitable the insulin regimens for various situations, like, the basal bolus, then definitely the 3 doses of prandial regular insulin and 1 or 2 doses of NPH insulin. For patients with the moderate to severe hypoglycemia, we have to regular diet pattern and experience the prandial excursion after each meal. The basal plus, that is 1 or 2 doses of the prandial regular insulin plus 1 or 2 doses of NPH insulin. So for the patients who have the moderate to severe hyperglycemia, who have a regular diet pattern and experience prandial excursion with 1 or 2 meals only, like the patients initiated on steroid in the morning only. The basal insulin with or without oral glucose lowering agents, these are suited for patients who have the normal prandial excursion less than 40 to 50 milligram per dl, but require the insulin therapy for control of basal or fasting hyperglycemia. Now, this is very important, that correctional insulin dose with or without the basal insulin. So it is not recommended for routine use. That should be only used in patients with erratic diet pattern, preferably with the basal insulin. And monitoring, I will just disclose later. Next. So this is the primary importance. I'm again saying this cultured in many, practiced in many ICUs, that the only the prandial correction with the only short-acting or ultra-short-acting insulin. That is after seeing the pre-meal the blood glucose level. So this is not recommended nowadays. We have to add some basal insulin first, and then the correctional values will be there with the short-acting, ultra-short-acting insulin. Next. So this is the blood glucose log showing the DET, the glucose, insulin, and steroid dose, and the before breakfast, after breakfast, before lunch, after lunch, before dinner, after dinner. Now, so 3 a.m. in some patients who have a the chance of early morning hypoglycemia, or at the same time, if the patient's the fasting sugar is rising in spite of increasing the basal insulin dose, then definitely we have to see whether there is any early morning hypoglycemia by measuring 3 a.m. blood glucose. Next slide. So what will the glycemic targets for most of the patients on the basal bolus insulin regimen, or for inpatient hyperglycemia management in general? Our blood glucose target pre-meal blood glucose value will be less than 140 milligram per dl, and the post-meal blood glucose value will be less than 180 milligram per dl. In selected individuals, the target can be less than 120 milligram per dl pre-meal and the 160 milligram per dl in the post-meal, provided this can be achieved without any hypoglycemia. Next slide. Now coming to the intravenous insulin infusion. Next slide. So as I've already mentioned, that it is advised only when the patients with when they are in nothing per mouth status, or having some erratic diet pattern from the time or the content of the diet concerned. If the patient have some emergency, like the diabetic ketoacidosis or the HHS, If the patient have uncontrolled hyperglycemia despite the multiple subcutaneous insulin doses, the patient have severe hypoglycemia at the onset, like with the pre-meal value blood glucose of more than equals to 300, or the post-meal blood glucose more than equals to 400 at admission, despite the use of subcutaneous insulin. The ketone status definitely we have to check before starting the infusion here to rule out the ketoacidosis. And critically, in like patients like the patients who are sepsis, septic shock, or next slide. Now, to initiate this insulin infusion, we have to give the dose of 0.05 to 0.1 unit per kg per hour, and we have to prepare it by 50 ml of normal saline with the 50 units of regular insulin in an insulin syringe, and we have to prime it with a 20 ml by discarding through the intravenous set. And after that, we have to be cautious about the hypoglycemia when we are infusing this insulin infusion. So monitoring should be cautious. Ideally, it should be monitored every hour, but in our setup, it's difficult to do. So at least the Indian government has published a few days back the guidelines that suggest that 2 to 4 hourly CBG monitoring can be done. Here, the glycemic target for the intravenous insulin infusion patients have the 140 to 180 milligram per dl, but definitely we can be more stringent to take it up to 110 to 180 in some patients who have a less chance of hypoglycemia and stringent control are required. But if the patient have the increased chance of hypoglycemia, like elderly patient, frail patient, the patient have hepatic renal dysfunction, definitely we have to be less stringent. And here we can allow up to 200 to 220 milligram per dl. The target range of blood glucose change that every hour, if it is less than 50, then definitely we have to increase the insulin infusion rate, and if the correction is more than 100 milligram per dl, we have to reduce the insulin infusion rate. And coverage of meal is very important. When the patient is able to take food orally with the insulin infusion, then definitely we have to increase the rate to 2 to 4 units per hour for the next 1 to 2 hours of this meal time. And definitely we have to switch to basal bolus regimen when there is the requirement of this insulin infusion is finished, like the patient when is clinically stable and can take food orally. So in that situation, we have to calculate the 80% of the total daily dose from the last 24 hours insulin infusion, the total amount of insulin infused, and after that we have to divide it in the 50-50 if you use the analog insulin, or we have to divide equally 4 times with the 3 times regular insulin and 1 time NPH insulin. Monitoring is serum potassium is very important because the insulin infusion is associated with a chance of hypokalemia, which can be detrimental for patients who have a respiratory failure. Next slide. So the take-home pulse from my today's presentation, definitely the COVID-19 and diabetes is strongly associated, and the control of diabetes is very important from that aspect that it reduces the mortality, morbidity, hospitalization, and also ICU transfer to the patients. Definitely at admission, we have to check the glycemic status by a random Cbg in every patient, and we have to correctly choose the anti-diabetic management. Which patient will require the oral anti-diabetic can be continued, and if the patients require the basal bolus regimen or the insulin infusion, proper monitoring is also very important to reduce the chance of hypoglycemia and at the same time the hyperglycemia. So here I have to mention a special point that the judicious use of the glucocorticoid, timely initiation and discontinuation is at the utmost important to avoid the hyperglycemia and the consequences. And it's not only to combat the disease COVID, but also to prevent the complications that we are actually seeing nowadays, the mucormycosis. So definitely this is a very important aspect of COVID management. Thank you for your kind listening. Organizers, please.
Thank you very much, Dr. Rai. It was quite exhaustive, and I'm sure the
So voice is interrupting a lot. I can't hear you properly.
I think.
Hello.
Yes, sir. We can hear you, sir.
Okay. Am I audible now?
Yes, sir. Yes, sir.
Okay. No, it was quite exhaustive and very good presentation, Dr. Roy.
Thank you, sir.
Very elaborate. I'm just wondering whether the COVID wards where the critically ill patients are being managed, whether they have a simple guideline, because as we know, that people who are managing COVID, they are by no means endocrinologists. Okay, and some of them might have some training in critical care management. Otherwise, most of the younger people who are managing COVID patients, they are mostly by broad guidelines or the prescriptions that are being made by senior experts in medicine mostly. Possibly not necessarily the patients are fortunate to get guidance or get the referral to the endocrinologists always. So whether my question is whether the Diabetology Society or the Endocrinology Society has made simpler algorithm for managing or for treating hyperglycemia, management of hyperglycemia in COVID patients. You have to remember the doctors who are treating COVID, they are non-specialists. Now, how the non-specialists in the COVID world should treat hyperglycemia, whether there has been a simple algorithm or simple guideline by the Diabetes Society or Endocrinology Society. That is the question.
Sir, till date there is not available, but definitely
Uh,
they will do it
there is
most
a
probably.
need. There is a gap here.
Yes, definitely, sir. I agree.
Okay, think about that. I think that will be really really good. That on admission, what should be done, and then during the stay in the hospital, what should be done for relatively patients so long they are not on, okay, they are not really too critical, they are still responding to your this thing and comments, and they are complying, and when to start insulin, whether from the very first day, or when would you think of switching from oral to insulin, or is there a need to start insulin therapy from the very beginning, keeping in mind the potential to actually turn to more severe or moderately severe cases? Okay, so this is also some issue that needs to be, and these finer details might be of interest to endocrinologists, but then the topic is that COVID management, managing hyperglycemia in COVID. Think over this. We'll get back again. Now, Dr. Shambo, let's go to Dr. Shambo. Again, I'll request Dr. Shambo to be brief and to highlight the association between these two. One is COVID and I'm sorry, the steroids, which is the cornerstone of management of COVID this day, today, hospitalized patients, and then the fear of hyperglycemia, that is steroid induced hyperglycemia, and how to avoid it, number one, and then if it occurs hyperglycemia, then how to manage it. So it appears that somebody who is not known as a diabetic, when he is reaching the hospital, there are different possibilities that he has already started taking steroid, okay, and by the time he reaches, you find that he has hyperglycemia, and then how to actually approach this patient. Okay, the patient is not a known diabetic, not a pre-diabetic either, but as he lands up in the hospital, you find he there is hyperglycemia, and at the same time he is on steroid. Then how to approach this kind of a patient? I would request Dr. Shambo to be a little focused and be brief so that we can have some discussion at the end. Thank you. Dr. Shambo, please.
Thank you, sir. Thank you very much. And I am very much thankful to Dr. Arindam Ray, who is a renowned endocrinologist in our city, for giving us time from his busy schedule. And he had beautifully covered many aspects of my talk also. And first of all, what sir has inquired regarding the guideline, I think government of India with AIMS endocrinology department, they had published one very good guideline on managing diabetic patients in COVID ward. And I think that is also available in net, and Dr. Arindam Ray has beautifully depicted some salient features of that particular guideline. And we are going to discuss about steroid-induced hyperglycemia in COVID-19. So here the word DM, that means diabetes mellitus, is missing. We are talking about hyperglycemia, but we all now facing one devastating epidemic that is known as mucormycosis. So devastating mucormycosis, to control that DM, that means devastating mucormycosis, we need to give emphasis on how to control another DM, that is diabetes mellitus. And for that, there is no alternate to another two DM, that means dexamethasone and methylprednisolone. So we need some concrete evidence-based guideline to manage this milieu. So without any delay, this is why we require dexamethasone in treating our COVID-19 patient. So this recovery trial had clearly depicted the need of dexamethasone. Very recently, one trial was published in this journal, Clinical Infectious Disease Journal, May 2021. This particular study with methylprednisolone, this randomized control trial, that has suggested that short course of methylprednisolone in hospitalized patients with COVID-19 did not reduce mortality in overall population. So this trial gives a big question mark to what we are doing in our for last almost 1 year, giving or treating our patients, moderate or severe COVID-19 patients, with methylprednisolone or dexamethasone. But there are scientists who dissect this trial very well, and they had found that the glycemic equipoise was not there between two arms, and they suggest that is the cause. The diabetes is not controlled, and that is the cause why there is no benefit is seen in the methylprednisolone arm. So we need to tackle this issue, this the hyperglycemia, steroid-induced hyperglycemia. Otherwise, we lost our COVID-19 patient. And in this cartoon, we can beautifully see how they are interlinked, how COVID-19 and diabetes is very much interlinked. And for that, I always prefer to describe this with one mnemonic, that is COVID. That means while we are seeing our diabetic patient, we need to give emphasis on few aspects. That is C. C means we should check other comorbidities, maybe renal compromised, hepatic compromised, cardiac compromised. So we need to elicit history of comorbidity and coagulopathy in our diabetic COVID patients. Next is O, that means obesity. And for that, we know that obesity is directly linked with increased morbidity and mortality associated with COVID-19. Next is V, and for that, the viscosity of blood. That means we always know the D-dimer level goes up. So that is very critical things, and for that, our diabetic patients need some protection against this increased viscosity, blood viscosity, and for that we generally use low molecular weight heparin, or in some case oral anticoagulant drugs, and some cases antiplatelet drugs like aspirin. Apart from that, I is very important, and it has been seen that by COVID-19 infection, COVID-19, the SARS-CoV-2 also affect the beta cell of the pancreas, because in the beta cell of the pancreas there is ACE2 receptor, and by that they decrease the insulin secretion. Apart from that, they produce another D, that means dysregulation of immune system, and that dysregulation of immune system also leads to insulin resistance. And apart from that, there are lots of cytokines that came into our blood circulation, which results in the hyperglycemia. So this synergistic action of SARS-CoV-2 and diabetes. So they cause increased mortality and morbidity, specifically when diabetes is not controlled. Now, while talking about steroid-induced hyperglycemia, this is one of the beautiful study which suggests that how the pattern of glycemic changes that has been seen with corticosteroids. So group 1, the lower, the cursor, is it seen, the cursor? So this triangular line, this is the group who are non-diabetic and they have no prednisolone. So you can see the features of the glucose level in their plasma. Now the second group, they are non-diabetic but receiving prednisolone. So here you can see at afternoon there is a surge in glucose level in the plasma, and that is the steroid-induced hyperglycemia. And in diabetes patient, the non-diabetic patients who are who has given the prednisolone tablet, so there is increase in the post breakfast and post lunch, and even it persists somehow at the late hours also. So this is very important. This phenomenon is important, and this is why we need to control this glycemic surge. Now coming to few definition, what is steroid induced hyperglycemia? So use of steroid treatment in people with pre-existing diabetes resulting in worsening glucose control, and that is called steroid induced hyperglycemia. Now what is steroid induced diabetes? So that is rise in glucose occurring in people without a known diagnosis of diabetes. So they are steroid induced diabetes, and sometimes this is reversible when we withdraw or deprescribe steroids. Now I am giving a few real life scenario just to stimulate our respected delegates views, that if a 63-year female who had developed COVID-19 pneumonia, comorbidity, other comorbidities like hypertension, diabetes, now admitted in hospital at day 7 of symptoms onset, saturation 87% in room air, CBG at emergency room 340 milligram per DL. She was on vildagliptin plus metformin fixed dose combination twice daily, and there was a report on HbA1c 6.9% 3 months back. Now patient admitted in CCU. So what should be done for this glycemic control of this lady? So in this particular lady, I think the insulin infusion, starting insulin infusion immediately is the correct option for this particular patient, because already the CBG is high. Now we need this patient to start with corticosteroid, and for that there will be again a very high surge of CBG. But before doing the starting the insulin infusion, also we need to check the whether the patient has DKA. We need to check the urinary ketone body. We need to check the pH value. We need to check whether there is less bicarbonate level. So ABG should be done. So this particular patient ABG reports was okay, normal. So urine ketone was negative. We had started insulin infusion, and as respected Dr. Arindam Ray had beautifully depicted about how we should titrate the insulin infusion protocol in hospital. So we had done that protocol, how to bolus dose, and then the titration of the infusion pump. I am not going in details, but that has been done for this particular patient. So next patient, a 48-year male, COVID-19 pneumonia, diabetes, hypertension, CAD, day 6 of symptoms onset, fever persisting, saturation 91% in room air, CBG at emergency room 246 milligram per DL, on sulfonylurea, metformin, empagliflozin, DPP4 inhibitor. Along with that, there is one HbA1c report. It was so 7.9%, not controlled as per this particular patient. We need much more control, particularly this patient. So patient admitted in ward. What should be done for glycemic control to this particular patient? So again, in this particular patient, we had started basal bolus therapy, and along with that, as this patient also need a glucocorticoid, dexamethasone, so we need to give one corrective dose of insulin prior to giving dexamethasone. Now another 36-year female, COVID-19 pneumonia, obese, BMI is 28, day 5 of symptoms onset, SpO2 was 90% in room air. The room air and the Cbg at emergency room was 176 milligram per dl. Now patient admitted in ward. What should be done for the glycemic control? So whether this glycemic control is deranged or not, this has been, I am not going in details, because again Dr. Ray has beautifully mentioned about how to when to start with therapy. But what I want to give emphasize in this particular patient, that we need to do follow-up Cbg values, because this particular patient, when admitted, she was admitted at around 6 p.m. but pre-dinner Cbg value was 160 in this particular patient, and 2 hour post-dinner Cbg was 240. So we can see the importance of checking glucose in the COVID ward, and that we should not miss in any patient who are this type of thing. So this particular patient, again, she need dexamethasone, and for that again there is a surge of glycemic load, surge of glycemia, and we need some insulin to this particular patient also. We had managed this patient with 2 doses of 1 doses of NPH and another corrective insulin, short-acting insulin, pre-meal corrective short-acting insulins. So how to manage COVID patient on steroids? This is taken from the Government of India guideline. Why we need insulin therapy in COVID? We mentioned about that eye, and that eye is very important because COVID-19 patients, maximum COVID-19 in hospital patients require insulin. So there is no alternative to that. And why is that? There is compromised beta cell function. And that is also worsened by SARS-CoV-2 infection, as I had mentioned. By disease severity is directly proportional to the worsening hyperglycemia, and also the cytokine storm that worsen hyperglycememia. We need to give higher dose of glucocorticoids, that also related to COVID-19, that the related hyperglycemia. And how we should initiate insulin therapy. So this particular guideline gives emphasis on NPH in morning and or bolus regular insulin at lunch in patients on once a day morning dose of prednisolone, and full basal bolus insulin regimen in difficulty to control blood glucose or use of long-acting glucocorticoid. But here I want to mention, in our practical experience, the use of prednisolone is very negligible in COVID-19. Generally, we use again that D and M, that means dexamethasone and methylprednisolone. And when we are using methylprednisolone, generally we use it 16 milligram twice daily. So this requires a full-blown basal bolus insulin regimen. And how to titrate that insulin dose? Dose escalation is relatively more than the usual initiate in regular protocols. We need to give more dose of insulin, specifically when the patients are on a high dose of glucocorticoid. And what should be the blood glucose targets? Again, here is one thing. The targets are little bit compromised, we must say, because the fear of hypoglycemia. As we are dealing COVID-19 patients, the Cbg monitoring is not that much like our other patients. So that cause we need to be little bit more protective regarding the hypoglycemia. So the target in this guideline, particularly, they had mentioned less than 220 milligram per dl, specifically the post meal. But it is always better to keep it between 140 to 180. and sometimes if possible, if there is a stringent Cbg monitoring, then we can make it 100 to 180. Insulin requirement changes dramatically with increase or decrease in glucocorticoid dose. So that is very important. And to understand this, I think this is a very beautifully done randomized control trial in New Delhi by Dr. Om J. Lekhani and Professor Sudhir Tripathi. So I want to discuss a little bit on this protocol, because this protocol can help us regarding managing our steroid-induced hyperglycemia patient in a COVID-19 ward. So the basis of this protocol is that giving an additional correctional insulin which matches the glycemic profile of the glucocorticoid administered, and that would negate the glycemic effect of the glucocorticoid. So just the pharmacokinetic pharmacodynamic matching with a glucocorticoid and a specific insulin, that can give some huge benefit. So I am not going in details, you can find it in from net, that how they divide different groups. So first of all, if the patient is not a diabetic patient, so in that case, that is the HbA1c level is less than 6.5%, and as Dr. Arindam Rai has rightly mentioned the importance of measuring HbA1c in the next day of admission. So we need to check HbA1c to understand whether the patient has pre-existing diabetes, or if the patient has diabetes which is controlled or not. So HbA1c has a very huge value. So we need to know what is the HbA1c level, and then we need to know whether the patient is non-diabetic, whether the patient is diabetic but it was undiagnosed. Then the question comes whether the patient is non-diabetic but not on basal bolus insulin. Then the last column is that non-diabetic on basal bolus insulin. Now we have to decide as per the HbA1c value. I am just giving one example, that if a patient come to us with a HbA1c value of say 5.8%, and there is a steroid-induced hyperglycemia, and we need to give methylprednisolone to that particular patient. So how we can tackle that patient? So if it is less than 6.5% and the patient is not known diabetes, so we can give one dose of correctional insulin along with that methylprednisolone, and that can be NPH with that methylprednisolone. If I am giving methylprednisolone once daily, that can take care of the whole glycemic load. So if again another example, if a patient come to us with an HbA1c value of say 7.9%, and he is non-diabetic but not on basal bolus, now we can, what thing we can choose? So you can see here, we need to give first one background insulin, and that should be started with 0.4 unit per kg dose, and along with that 0.4 unit per kg dose means if his body weight is 60 kg, so we need to give 24 unit of insulin, and if we are using analog insulin, then we need to divide it in 50%, 50%. So 12 unit basal insulin, maybe glargine, and 12 unit bolus insulin divided into 3. That means before breakfast 4, before lunch 4, before dinner 4. So 12 versus 12. Along with that, we need to give a correctional insulin administered along with that particular glucocorticoid. If I am giving this particular patient dexamethasone, we need to give a long-acting insulin along with that particular dexamethasone dose. So what should be that particular dose? I am coming in a later slide. So I think this protocol has clearly mentioned how we can we can use insulin in patients who are diabetic and need corticosteroids. Now, what should be the starting dose for total calculating the insulin dose? If it is less than 6.5%, we can start 0.3 unit per kg for those who are non-diabetic. If it is 6.5 to 8.5, it can be 0.4 unit per kg. More than 8.5, it can be 0.5 unit per kg. But we should always respect that if a patient has compromised kidney function, age is more than 70 years, the starting dose should be a little bit lower, maybe 0.2 unit or 0.3 unit per kg. And how we can change the basal insulin dose? They had used this formula. If the next day fasting blood glucose is more than 200, they increase the basal insulin dose by 20%. If it is between 140 to 199, then increase basal insulin dose by 10%. If it is between 70 to 100, then reduce the insulin dose by 10%. And if it is less than 70, reduce basal insulin dose by 20%. So the optimum fasting blood glucose, target plus fasting blood glucose, is between 100 to 140. Now, CBG monitoring, in this particular trial, they had done 4 times a day, fasting, pre-lunch, pre-dinner, and bedtime using a glucometer. And the target that I had already mentioned, the pre-meal was between 100 to 140. The post-meal, or they specifically target the bedtime blood glucose, that means 2-hour post-dinner blood glucose, that should be between 140 to 180. And they also used a supplemental dose of pre-meal insulin. So that means, as they had checked the fasting, pre-lunch, pre-dinner, so as per the fasting, pre-lunch, pre-dinner value, they had given some supplemental insulin dose of regular insulin or analog insulin along with what was calculated before. So this was the supplemental insulin dose. So it has been generally used when the patient is on hydrocortisone. The pharmacokinetic, pharmacodynamic parameters are matched with regular human insulin. If it is prednisolone, then insulin NPH and methylprednisolone, also insulin NPH can match. And if we are using longer acting like dexamethasone, insulin glargine and insulin digludac has a matching property with pharmacokinetic and pharmacodynamic characteristics of dexamethasone-induced hyperglycemia. And this is this dose relation is also very important, because how much correctional insulin I am going to give. So now for that, we all know this formula, that dexamethasone 2 milligram is equivalent to prednisolone 8 milligram, methylprednisolone 8 milligram, prednisolone 10 milligram, and hydrocortisone 50 milligram. And so for each 2 milligram of dexamethasone dose, we need to give one correctional insulin 0.1 unit per kg. So assume a patient who needs 8 milligram of dexamethasone. So for him, that we need to give a correctional insulin glargine or insulin digludac of 0.4 unit per kg. If the body weight is 60, so we have to give 60 into 0.4, that means around 24 unit correctional insulin along with that particular dose of steroid. So this was the thing they had mentioned, that they had used, and they had clearly shown the benefit in terms of the glycemic variability, lesser hypoglycemia, and much more control. That time the time in range concept is not there that much, but they had shown there is clearly benefit in favor of this particular protocol compared to the conventional protocol. So this was a very I think a very useful tool even nowadays, because we need to use corticosteroids. There is no other option. So we can follow this guideline, follow this protocol, and we can see, and there we can plan. We can plan another research also in this using this this protocol, whether it is matching in our day-to-day practice also. So this is I think very important. And now I am going to that particular guideline, which was also beautifully mentioned by Dr. Ray. I am not going in details because already Dr. Arindam Ray had covered this topic. So this generally giving the emphasis on when we should start treatment and you can see first we have to check a CBG at the time of hospital admission. Then we need to perform a pre-meal and 2-hour post-meal CBG with the first major meal in the hospital, just like I had shared our that 36-year female patient whose entry CBG was around 178 like that, but when we checked the pre-dinner and 2-hour post-dinner CBG, it was high. So we need to send the blood for fasting plasma glucose and HbA1c next morning, and then we should check these numbers. So we need to monitor CBG before breakfast, before lunch, before dinner, and after dinner for at least 2 days for underlying hyperglycemia if any of the test values are high. So we need to check the patients, and if there is any random CBG value more than 180, pre-meal more than 140, post-meal more than 180, and the fasting value more than 110, HbA1c becomes more than 6%, and we need to be we need to give a vigilant eye on this particular patient. But pharmacotherapy requires, if the random CBG is more than 250, pre-meal more than 150, post-meal more than 200, fasting more than 126, and HbA1c more than 6.5%. And as I had already mentioned, we need to do the ketone body test, urinary ketone body test, check the pH and bicarbonate level if the CBG at any time more than 250 milligram per DL. So we need to be very clear on that. We should not miss diabetic ketoacidosis patients. So blood glucose monitoring strategy for individuals with no evidence of stress hyperglycemia or undiagnosed diabetes at the initial screening, this has been already mentioned. And we need to give, even the patient CBG is normal, but patient is initiated on steroids, we need to give emphasis on this CBG monitoring, and this CBG monitoring should be done daily and at least for initial few days, and it should not be decreased if we have enough feasibility. And these are the other patients where we need to monitor blood glucose twice a day, every 3 to 4 days. But patients is on steroids, we need to check all these levels before breakfast, before lunch, before dinner, and after 2 hours after dinner. So guidance on the use of insulin therapy in our guideline, in Indian guideline, they had clearly mentioned prescribe insulin if there are contraindications to oral glucose lowering agents, or the patient is suffering from moderate to severe COVID or moderate to severe hyperglycemia. That means pre-meal more than 180, post-meal more than 250. Now, I think all the patients who are now admitting in our hospitals, they are suffering from moderate to severe COVID. So ideally, as per the guideline, they should fit in this insulin therapy group. And when we required intravenous insulin infusion, it has been beautifully discussed. I am not going in details. And how to use basal bolus insulin regimen, we had already discussed and in our previous slides. So now, while using steroids in Government of India guideline, they had also classically mentioned when to use which insulin and what are the different other conditions. So if there is no previous diabetes, but there is hyperglycemia, so we need to give 0.2 unit per kg per day. So 1 dose of NPH, 0.1 unit per kg, morning dose, along with that dexamethasone or methylprednisolone. But I think there may be debate with that, what I am talking now. But I think when we are using dexamethasone, which is a prolonged acting drug, we need some analog insulins like glargine or degludec. But when cost is a constant, NPH is also very good. So regular insulin, 0.1 unit per kg before lunch. So the dose is 0.2 unit per kg per day. Morning dose NPH, 0.1 unit per kg, along with that particular steroid administration, along with regular insulin, 0.1 unit per kg before lunch. Because again, if we just revisit that diagram, that steroid-induced hyperglycemia pattern, we always know that the afternoon, 2 hour afternoon, 2 hour post lunch is that period when there is maximum glycemic surge happen. But when the patient is already known diabetic, already on 1 or 2 oral glucose lowering agent, then the dose should be 0.4 unit per kg per day. And here we need to give NPH 0.1 unit per kg, a morning dose and evening dose, along with regular insulin 0.1 unit per kg before breakfast, before lunch, and before dinner. So when to give that NPH 0.1 unit? Because here NPH 0.1 unit per kg is one dose only. So generally it is preferred, it should be given along with that particular steroid what we are using. But again, I am mentioning here, it is if we are using methylprednisolone twice daily, or if we are using dexamethasone tablets which are prolonged acting, it is generally better to use long acting insulin analogs. Now, when the patient's already on more than 2 oral glucose lowering agent, they require higher units, so 0.6 units per kg per day. Here they require 2 doses of NPH, 0.2 unit per kg morning dose and 0.1 unit per kg evening dose, along with regular insulin 0.1 unit per kg before breakfast, before lunch, and before dinner. So this is the formula. And diabetes on insulin more than 0.6 units per kg per day, already patient is taking a huge amount of insulin. Now what to do? Now the dose calculation is like that, we have to give 20% extra to that particular patient. So 1.2 into patient's insulin dose units per kg per day. So we need to multiply 1.2, and again here we need 50% NPH, and for that 2/3 NPH dose will be given in the morning, 1/3 will be given in the evening, and 50% regular insulin divided into like that before breakfast, before lunch, and before dinner. And we need to monitor the sugar level. So when the patients are on insulin and they have steroid-induced hyperglycemia, we need to check the Cbg like this log. So we have to enter the glucose value, we have to enter the insulin dose, and we have to also mention here date wise the steroid dose, because as the steroid requirements decreased, there is a marvelous response in the insulin dose requirement. So the insulin dose was so much decreased along with that steroid dose decrease, tapering of the steroid dose. So these are the times 3 AM value is important only when there is fasting hyperglycemia. If our patient is having some fasting hyperglycemia, it is important to see whether the patient has Somogai effect or Dawn phenomenon. So that can be that can be seen if we check the 3 AM Cbg value. What should be the advice on discharge? Those patients who are on this type of steroid-induced hyperglycemia, so who maintain their blood glucose levels with oral glucose lowering agents during admission, we can continue same medications and discharge. Who were on basal bolus insulin and the dose is very high, that means that particular patient require more than 1 unit per kg per day dose. So same insulin regimen itself we can prescribe while discharging with some reduction in the total insulin dose. We need to consider if we are deprescribing steroids completely, so there is a gradual reduction in the insulin requirement. But individuals on insulin dose, moderate insulin dose, that means 0.5 to 1 unit per kg per day dose, so they require, we can prescribe them twice daily premix insulin and oral glucose lowering agents along with that. Patients who required only low dose insulin, low dose means here less than 0.5 unit per kg per day, and there is no other medications to control that particular hyperglycemia. So these particular patients can be discharged on different oral glucose lowering agents like DPP-4 inhibitors, metformin, sulfonylureas, after careful considerations of drug safety, patient-specific factors. And there are some studies also with SGLT2 inhibitors post-COVID. I am not talking about acute ill COVID-19 patients. Post-COVID-19 patients, they can be the SGLT2 inhibitors can be used with checking the other safety issues. So, summary of today's presentation: there is positive results from recovery trial that tell us that the need that emphasize the need of glucocorticoids among patients with moderate to severe COVID-19. So we need to prescribe glucocorticoid. There is nothing like that. My patient has high blood glucose, so we have to wait with insulin therapy for 2 to 3 days. Then the glucose value will go down. Then I will try to inject glucocorticoid. No, that is wrong. If the patient requires glucocorticoid, irrespective of CBG value, we should start glucocorticoids. Along with that, we need to give emphasis on glycemic control with insulin. That insulin dose can be titrated, but there should not be any delay in while starting glucocorticoids when it is really needed. So high dose glucocorticoid, they increase the risk of hyperglycemia, but we have insulin to counter that. So previously well-controlled diabetics sometimes require large dose of insulin, maybe more than 2 units per kg per day. That can be happen, but we need to have insulin and steroids matching with them with their pharmacokinetic and pharmacodynamic properties, and we can use easy guidelines to help our patient. So for patients with uncontrolled hyperglycemia, despite the use of basal bolus regimen, the use of intravenous insulin infusion should be considered, and there should not be any delay in starting intravenous insulin infusion. And there are beautiful protocols with that, how to use insulin infusion. So with that, I thank you. I again want to thank Professor Santanu Kumar Tripathi sir and Dr. Arindam Ray sir. And we have today, I think there is some preoccupied things with Professor Shashank Joshi sir, so he is not able to present till now. So I am thankful to him also. Over to you, sir.
Thank you very much, Dr. Samajdar, and you have very elaborately discussed yourself and Dr. Arindam Ray. There is hardly anything left really to emphasize any further, but particularly the Government of India guideline that has come quite recently, and to what extent this is being implemented, okay, at the hospital level, that is to be seen. To the best of my knowledge, there was no separate guideline in West Bengal, at least from Government of West Bengal. I don't know if there is any guideline. This Government of India guideline, whether it is being implemented in most of the, or if not all of the hospitals for COVID management, that needs to be seen. And at the same time, I would again harp on both Dr. Roy and Dr. Shambo Samajdar, that can you think of taking the principles, can you think of a more simplistic kind of guidance document for the COVID hospitals, where I believe now that most of the people who are actually at the helm of affairs in managing on a hour to hour basis, they are actually non-specialists. So more simplistic kind of guideline, algorithmic, that would be really helpful if it can be done. I would also request if whether we can do this from iNovoCare platform, that also you may consider. Both of you can take the responsibility, and we can have a small group, and then we can have one or two more experts. Dr. Shashank Joshi was not available today. We can also take his help in formulating a simpler kind of, the skeleton might be, the principle might be the Government of India guideline. Secondly, I'm not sure whether I have seen it correctly, that you have, while you defined that uh, steroid-induced hyperglycemia has to be by definition in diabetic subject. So if somebody who is non-diabetic or pre-diabetic and land up with hyperglycemia, what do you call them? So and then in second case we have said that if hyperglycemia is steroid induces hyperglycemia, can you go to that particular slide? There was one slide in which you have the, I think the third or the fourth slide, Dr. Samajdar, you had shown the definition of steroid-induced hyperglycemia. But then somebody who is a non-diabetic, neither a pre-diabetic, and then if he has started steroid, there are two factors. One, the stress of COVID itself, it's an acute infection, and again there is steroid exposure or steroid being given, whatever be the dose. Now together, it as I believe, as I understand, that should be enough to actually lead to hyperglycemia or rise in glucose. So what do you call it? It is a drug-induced hyperglycemia. Now, if you define that it is only when the person is pre-diabetic or diabetic, then only you call it steroid-induced hyperglycemia. I don't know really whether I have
In this
understood it.
particular article in the Diabetes
Uh,
Journal of Diabetes and Medicine, Diabetes Medicine Journal, Roberts A. et al. So he had defined like that what you are saying, that is actually a steroid-induced diabetes, and they had mentioned that the rise in glucose occurring in people without a known diagnosis of diabetes. So there can be pre-diabetes, they can be already they have may have diabetes, we don't know. But here the differentiation is with that
no, no.
particular
Tell me.
HbA1c value.
No, no. Tell me what they have defined. Steroid-induced hyperglycemia. How do you define it?
So they had defined that use of steroid treatment in people with pre-existing diabetes resulting in worsening glucose control. So this is a
But
simplistic
if if somebody does not have a pre-existing diabetes,
so that
yet
is
there is
steroid-induced diabetes.
hyperglycemia, that
So
is not steroid-induced. What do you call it?
that is steroid-induced diabetes.
No, it's not steroid-induced hyperglycemia. You mean?
No. That is if the patient does not have pre-existing diabetes without a known diagnosis of diabetes, and if there
Right.
is a rise in glucose, then it is steroid-induced diabetes. And steroid-induced diabetes is a entity which is also reversible sometimes,
Okay.
or we can say drug-induced diabetes, like that.
Okay, but then by common sense, it would have been the other way around. That if it is hyperglycemia caused by steroid, it is steroid-induced hyperglycemia. Okay, if the patient is otherwise diabetic or pre-diabetic, and because of poor control prior to getting COVID, or even after getting COVID, poor control, and landed up in a hospital with hyperglycemia, that is poor controlled diabetes, and then steroid is an additional factor that has caused this
Yeah,
hyperglycemia.
sorry,
In any case, that's a debate,
yeah,
but then we need to look into it. But you are very nicely, you have also described the chronopharmacodynamics of hyperglycemia because of these two factors, and how if one can plan also, and the additional dose of the insulin whenever you are going giving the steroid. So that is also very important, and it is very, I appreciate really when you talk of dexamethasone has a relatively longer effect so far as its impact on the on the glucose level is concerned as compared to methylprednisolone. There is also another factor, and that is the circadian rhythm, and how you are adjusting with that circadian rhythm. Methylprednisolone you are giving twice, and dexamethasone I think you are giving only once. And if you are giving once, what time you are giving, that is also important. But there is a lot of scope for research in this area, and two things as I leave, two things I will be emphasizing on. One, devising a relatively simpler kind of guidance, which uh, generalists would be able to really implement under the uh, very highly difficult environment of patient management, okay, in a COVID ward. And secondly, uh, doing little bit of research, how really diabetes or hyperglycemia is being managed. We can say many things, but then how and to what extent it is really being done, okay, on the field. So whether we can also try to generate some data on that. Okay, with these two asks rather from two of you youngsters, I would leave here. I would have loved to remain and engage in further discussion, but I have another preoccupation. I have to join in another webinar right now. Otherwise, you have done a marvelous job, both of you. Thank you very much, and wonderful presentations. And I think all the people who have listened to this, they have thoroughly enjoyed and benefited. And I suppose this will also be available, the recorded version, that those who missed it, they can also join later. Thank you very much. Over to Rohan.
Thank you so much, Dr. Tripathi. Thank you so much, Dr. Rai, Dr. Samajdar, for this wonderful evening. But I would be really happy if we can continue with what Dr. Tripathi said, and actually, instead of ending this as a one evening of discussion and taking this forward to something even more concrete and something that can be taken out in another platform, can be showed to people and can be used to help people. We are still helping people with all the wonderful talks you gave in spreading awareness, but I think if we can actually come up with a guideline or protocol that can actually help in uh, management of this disease, then that could be an even more worthwhile use of the, and it would even take the meaning of this evening even further. So that remains my humble request to all of you. I, in my own abilities with iNovoCare Health Hub Solutions, will try my level best to assist you people in any way you want me to, in order to make this happen. We can, I can also reach out to other doctors. If you tell me whom to reach out to, we can definitely do that, and it would be my honor. Dr. Samajdar, yes.
I have one request to you, because I know your technological efficiency. So there is one calculator specifically how to manage the insulin infusion rate in hospitals. So I
Okay.
request you also to see that matter, and whether this can be done in our setting and we can offer to our doctors. Now in every ICU they have their tab. So whether that type of software can be included in that particular tab, and we can optimize our patient care, specifically diabetes patient care. So I request you to please nourish this matter.
That would be great. Actually, we are.
Okay.
It would be. We would look into it definitely. I promise you that. So it's great. It's a wonderful input that we got today. So with that, I think we have already moved half an hour past our scheduled time. So, but it did not
Thank
feel
you.
even one moment extra due to our speakers. So I'm really thankful to all of you for joining tonight. Thank you so much once again, Dr. Roy, Dr. Samazdar, and Dr. Tripathi. So with that, we will say good night for tonight,
Thank you very much.
and we
Thank you.
will
Thank you. Good
surely
night.
come back very soon with another
Thank you.
program. Thank you so
Thank
much.
you. A special
Thank you.
thank you
Thank you.
to
Thank you, Dr.
Arindam
Rai.
da.
And
Arindam da.
thank you
No,
so
no,
much,
nothing
Dr.
mentioned
Rai,
at
Yeah,
all.
for
of course.
That's not a problem.
being
Thank
there
you.
Of
Thank you,
course.
everybody.
and
Stay
arriving.
safe and good night.
And I would like
Thank
to
you.
also mention for everyone there that Dr. Rai arrived at a very short notice. He came to our rescue,
Yes.
and so that for that we are especially very thankful to him. Thank you so much, sir.
Yes, of course.
Thank you. Thank you, everybody.
Thank
Good
you.
night.
Thank you.
Good night.
Good
Night.
night.